Okay, so good morning, everybody. Good morning, Main Arena 1, and welcome to this symposium sponsored by Boston Scientific with a very nice, interesting, challenging title, actually, Questions and Answers. Questions, definitely, answers, hopefully, on modern-day SFA interventions. And so, luckily, I don't need to solve these questions and answers all by myself, but I'm surrounded by an esteemed panel with Sabine Steiner, with Osama Ida. I didn't see Osama yet. He's there. You can join, please. And Thomas Zeller and Jan Guifik. So I'm Koen de Loze from Belgium, and it is my pleasure and honor to invite Sabine for the first presentation. So we all know how important vessel preparation is, but seemingly, what are we getting wrong with vessel preparation, Sabine?
Thank you very much, Koen, for the nice introduction. So you already presented the topic of my presentation. Here are my disclosures. Well, over the years, we really learned a lot of lessons with respect to how do we actually use drug-eluting technologies. And we just have to keep in mind the purpose of a DCB really is to lay down the drug in an adequately prepared vessel. So some key lessons dating back to the LEVANT-2 trial is that we need optimal drug delivery. One issue here is balloon transit time. This is quite specific to the Lutonix balloon, but really what it applies to all DCBs is we have to take care about balloon inflation pressure, balloon inflation time, and of course the final percentage of diameter stenosis. If we achieve here an optimal result for all four variables, we can expect the best patency outcome. But what we also know, we are not so good in judging residual stenosis when we look at comparisons between operator versus core lab adjudication. Operators consistently overestimate procedural success. We have documented that in the real PTX trial, where here the discrepancy was over, let's say, 35% between in the DCB arm between site estimation and core laboratory analysis with respect to residual stenosis above 30%. This was also seen in DISRUPT-PAD3, where the site-reported procedural success rate was substantially higher than when adjudicated by the core lab. And this was especially true for the interventional group, so for the intravascular lithotripsy group, where we as operators wish really to have a very good result. IVIS DCB assessment can help us here, and this has recently been documented by a presentation at the ACC a few weeks ago, where we see that especially in complex lesions, the primary patency rates are better with IVIS use, probably due to a better lesion preparation and less residual stenosis we leave behind. The IMPACT trials also highlighted the predictors of failures. And one important predictor really here is residual stenosis above 30%. And this is true for the outcome patency as well as binary restenosis as well as TLR rates. So residual stenosis above 30% is really a failure boundary, not a target. This afternoon, I'm going to present compare 5-year data. This is just an analysis on both populations taken together, but just stratifying the group at index procedure of residual stenosis above and below 30%. And what we can see here is that over 5 years, the Kaplan-Meier estimates for freedom from TLR are substantially better when we go for less residual stenosis. Bailout standing rates are another issue when we talk about optimal vessel preparation, and we know from many trials that especially in very long complex lesions, we stand about half of all lesions. So is stent avoidance with adjunct devices possible? This is an analysis from DISRUPT-PAD3 again. Importantly here, stent placement was seen as an early patency failure, and you can appreciate that the PTA standard arm had a worse patency over time, but this was mainly due to this early stent implantation. So it actually didn't have an impact on the long term after this initial stenting. Jet stream atherectomy plus DCB registry really looked at long lesions, mean lengths over 24 centimeters. And here the procedural, or let's say the technical success rate of a residual stenosis below 50% was very high after jet stream atherectomy, and the procedural success, so below 30% residual stenosis, was almost 100% after additional DCB use. And this translated to a very good TLR rate of freedom from TLR over 92% at 1 year using this strategy. Vestas FA has been published recently. It compared a stent avoiding versus a stent preferred strategy, really encouraging adjunct vessel preparation. And what we see here mostly scoring, balloons, atherectomy, and mechanical thrombectomy were used. But despite the use of this adjunct vessel preparation, we still needed a lot of bailout stenting in the stent avoiding, so in the DCB arm, which was almost 50%. And what we can appreciate is that the length of the stents, of course, was shorter than in the stent preferred group, where kind of a full lesion coverage was pursued. Importantly, despite all these measures, final stenosis was still high. Residual stenosis above 30% was still 45% in the DCB arm, and also about 1/4 in the stent preferred arm. So we have to do better to prepare the vessel before DCP use. And one thing is really optimal pre-dilatation and preparation. Visualization of the vessel in a high quality angios. Also, the use of IVOS can be helpful here, as we've seen in the live cases. Residual stenosis above 30% dissection lesion lengths are quite important factors, maybe to use DES instead of DCB. And if DCB is used, then really a little bit overstretching the artery by 10% with an adequate inflation time. And we should not leave residual stenosis behind. What about DES optimization? Do we have here some factors we can control? This is a very important registry by Stephen Kumm, where he looked at the outcomes of Eluvia DES with various strategies. So a lesion assessment was performed on a 2-view angiography, pre-dilatation in a 1-to-1 fashion to assess recoil and dissection, and then decide for DCB or DES or a hybrid combination. Aggressive pre-dilatation with non-compliant balloons were performed before DES implantation, so really to ensure optimal stenting results. And we can appreciate an extremely high patency rate after this strategy of over 90% at 12 months. From the capsicum study, we have seen that before. We know some factors for restenosis. So spot stenting, but maybe this is also due to geographic miss, as drug-eluting technologies probably were not used in combination that often, should be avoided. And lesion length is here not a factor for Eluvia DES restenosis. Importantly, we know that poor stent expansion is a risk factor for re-interventions and patency loss. We know that from the era of bare metal stents, but nowadays, of course, we have more modern technologies. And we have learned from the IVOS studies that really poor stent expansion affects patency. So if the minimum stent area is less than 15.5 square millimeter, this is clearly a risk factor for restenosis. This was also documented in insights from the capsicum trial, which have been published recently, that we do need an optimal minimum stent area in order to achieve long-term patency rates. So some rules for stent deployment are taking away from the supera approach, but most of them really also hold true if you go for DES implantation. Appropriate vessel prep is essential. Slow deployment also helps here. And of course, magnifying up the picture so that you really see what you're doing with high quality images. It's best to stent from healthy to healthy and to do balloon boss dilatation, and of course to ensure an appropriate runoff. So every stent really deserves a supera kind technique, as all these materials, of course, are going to stay forever in these arteries. So here are some key steps for DES optimization: optimal predilatation preparation, again visualization with high quality orthogonal angios. Quantitative angiography could also be helpful, especially in the case if IVUS is not available. Residual stenosis above 30% dissections, lesion lengths are really decision factors favoring DES, and total lesion coverage might be better than spot stenting, especially if they are not to leave behind a geographic miss. Slow deployment, of course, is also crucial here. So the golden rules for any drug-eluting deployment: prepare your vessel well, maximize the lumen, whatever drug-eluting technology you're going to use. Assess dissections, recoil areas, residual stenosis accurately, and then decide on a strategy between drug-eluting stents or drug-coated balloons. And then, of course, the deployment for both, for drug-eluting stents as well as for drug-coated balloons, should be optimally to transfer the drug into the vessel wall. So in conclusions, adequate vessel preparation remains key to drug deployment, no matter which drug-eluting technology is used. We do have operator controllable factors, and they are really significant for outcome. Predilatation, leaving no residual stenosis, leaving no high-grade dissection, good lesion coverage, or avoiding geographic miss, as well as stent undersizing. More liberal IVUS use may also improve the analysis, troubleshooting, and decision-making, as well as, of course, the most important, the clinical outcomes. Thank you very much.
Thank you very much, Sabine. And so probably after this, there is some time for short discussion instead of having all the discussion at the end. If there are questions or points of disagreement in the audience, please go to the microphone in the middle here and ask your question. Meanwhile, if there are panelists with some question, feel free. I have some question for you, Sabine. So this was a fantastic, a great presentation based on literature, on data. Now we go back to the daily reality. So how do you handle this in your own practice? You have a task D lesion 20 centimeter, in the middle occluded. I noticed out of your presentation, vessel prep is essential, but you are also using your vessel prep as a kind of judgment tool, what you're gonna do as a definitive treatment. So how do you handle this now practically? How do you judge it? How do you assess your vessel prep? And then at the end, how do you decide what to do as definitive treatment? Very practical.
Well, very practical. It starts when you start talking with the patient, you know, about the symptoms and at the clinical stage, if it's a CLTI or claudicant patient. So it's a full picture. It starts with the whole impression of the vessel anatomy. Do you have very diseased vessels in general, or is it just an SFA occlusion? These are all the factors that tip into a certain direction, also the age of the patient, of course. And then the most important thing is via passage. So what impression do you have from your lesion? Can you go for an intraluminal approach? Do we really have to switch subintimal? Maybe it's both areas you have done. So all this kind of stuff, I think, give you an impression how difficult this lesion will be to be treated. And then, of course, thorough predilatation. I think we use less undersizing for predilatation than we used to do so. So to get a better impression how much dissection and recoil you will have to face. And then also, as Andre showed, especially I think one of the things why scoring balloons works so well, because you do a thorough predilatation over a long time, and you really kind of achieve a good outcome here. So I think all these measures point towards a certain direction. I mean, IVUS use is still an issue for us due to reimbursement issues. I wait for the sentence. Belgium is a poor country from your side, so I'm sure it will come today. we don't use it on a regular basis. There has been published a cardiology study just recently in JAMA Cardiology comparing quantitative angiography and IVUS use. And it was very interesting to see that they had the same outcome with respect to treatment. So that might be a good option to move forward if you don't have IVUS available. And I see Thomas Seller wants to comment, I think.
Yeah, that's my criticism to all these IVUS-based studies. They did compare to angiographic eyeballing evaluation, not to QA. And if you are using the technology you have available in your cath lab, and this is QA, you can achieve almost the same outcome results as using IVUS. There's no big difference. And that's why I'm a little bit skeptic regarding the hype of IVUS. You have the technology already in place in your cath lab for proper lesion evaluation. In my opinion, there's an overuse of IVUS coming, which is not really indicated. But what you mentioned very importantly is the key for long-term success seems to be independent on the kind of therapy you are applying. The key of success is really to reach a residual stenosis of less than 30%. And that's true for every time of treatment, type of treatment, whether it's DS, whether it's bare metal stent, whether it's DCB. That's the game changer. And therefore, it's so important to achieve a residual stenosis of less than 30%, for example, before you apply a DES. We have seen the live case from Dr. Nakama with the compression of the Illuvia stent and with a residual stenosis based on IVUS of about 50%. This is a predictor of failure in the future. And this has to be avoided before implanting a stent. So vessel preparation is really crucial.
Do we need to be a little bit more strict of this 30%? We know in a lot of clinical trials, residual stenosis of 30% or less is seen as a success parameter. For me, 30% is quite liberal. So is this also your idea? Do we need to go a little bit more strict and go for 10, 20% residual stenosis, the maximum?
Well, the more luminal gain acutely you can achieve, the better. That's my true belief. We have not the data except what Dr. Steiner could show in the COMPARE study that independent on the type of DCB, if you have this 30% threshold, you see the difference already in clinical outcomes. Of course, if you can result in less than 20 or 10%, it may be even better, because this is what coronary studies have shown. The bigger, the better is the outcome. So the luminal loss over time is less if you have the better acute outcome.
So Thomas and Sabine, if I hear you very clear, it is not the time yet to go to our healthcare providers and payers and ask for a routine reimbursement of IVUS during all our peripheral work. I know that in Japan you are using it definitely on a routine base. So do you have like a kind of a comment on this, where we in Europe are probably not so convinced to use it in all our cases, and you use it 100%, Dr. Ida?
Thank you very much. So I partially agree with Thomas' opinion, but in my practice, I conditionally use the IVUS for especially the complex region.
Yeah.
This is, I think, the real world. But basically, I think the SFA intervention is not standardized in the young physician, especially for education. I think the IVUS is a very good tool to decide the right direction. But anyway, the proportion of the IVUS is around 60% in Japan in the SFA intervention, not routine use right now. Thank you.
Thank you very much. Thank you, Sabine. I think we need to continue. I'm here looking at the screen. Dr. Tatsuya Nakama is also preparing a live case during this symposium, but he's not 100% ready yet. So I think we can move on with the next speaker, Dr. Ida. So we had already the assessment, we had the vessel prep, and now we go to the definitive treatment. And drug-eluting technologies, definitely, but DCB or DES, what is the Japanese view on it?
Okay, thank you very much. So here's my disclosure. So I would like to start my presentation about the current situation in the Japanese femopopliteal practice. First, the bare metal stent is not reimbursed when used concurrently with the DCB. The indication for DCB treatment required successive vessel preparation. Second, in 2023, proportion of the DCB used in the Japanese femopopliteal practice is over 60%, while the frequency of the stent-based treatment is gradually decreasing by approximately 30%. So there have been several studies comparing the DCB versus the DCS for the treatment of femopopliteal lesion. Both studies demonstrated the comparable effectiveness and the safety of the DCB plus barrier stenting versus DCS in the femopopliteal intervention. So in Japan, 2 large-scale clinical studies was being conducted to evaluate drug-eluting therapies. One is a popcorn registry, which evaluated real-world DCB performance for over 2,000 patients. Another one is a capsicum registry, which evaluated real-world Eluvia DS performance for over 1,000 patients. Both studies reported that CTO and the vessel diameter was significantly associated with the loss of primary patency, whereas the lesion length was not. So ultimately, clinical question in the drug-eluting era is which is the best treatment for contemporary femopopliteal lesion in the Japanese practice. The Capricorn study compared the impact DCB versus Eluvia DS using the propensity matching analysis from the popcorn and the capsicum registry. So baseline characteristics before and after matching are shown here. Notable significant difference characteristics was observed between the DCB versus DS, representing that role of each device is somewhat different in the real-world practice. This slide shows a 1-year clinical outcome. 1-year restenosis rate was significantly lower in the Eluvia DS group than in the impact DCB group. Outcomes except restenosis were not significantly different between the group. So interaction analysis was shown in this slide. There is no interaction effect on the association of the DCB versus DS with the 1-year restenosis risk. Subgroup with the dialysis, claudication, the de novo lesion, the lesion length shorter than 20 centimeters, the no occlusion lesion, bilateral calcification has a better primary patency of the drug-eluting stent compared with the drug-coated balloon. So I'd like to introduce another retrospective study comparing the impact DCB versus Eluvia DS. Main purpose of this study was to evaluate whether the restenosis factor of the DCB are not as same as those DS. Similar to previous study, the primary patency rate was not significantly different between the DCB and the DS group, but numerically higher in the drug-eluting stent group with a 73%. So this slide including the important findings that smaller vessel and the nodular calcification was shared restenosis-related factor for impact DCB and Eluvia DS. Popliteal lesion and the plaque burden greater than 50% was restenosis-related factor for Eluvia DS, and a vessel preparation failure of the impact DCB. So here is a representative failed DS case with involving the popliteal artery. That this running position of the DS was extended to P2 segment, and the re-occlusion was occurred 1 month later. So here is a representative failed DS case with a plaque burden greater than 50%. The plaque burden of the distal stent landing position was greater than 50%, and the re-occlusion was occurred 3 months later. So on the other hand, the treatment outcome of DCB following the failed vessel preparation are unsatisfactory. Restenosis rate at the 30 months was up to the 82% if the DCB angioplasty was done after vessel preparation failure. So finally, I'd like to discuss about early restenosis after standalone DCB angioplasty. A CTO involving the SFA osteo was treated with the standalone DCB treatment in this case, but the early restenosis also occurred. Subsequently, drug-eluting stent was fully implanted for 4 reasons. DCB-RCT trial provides a valuable insight for the determination of the borderline between the DCB versus DES. If you take a look at the result of the RCT comparing the DCB with a non-coated balloon angioplasty, difference of the primary patency between the DCB and the non-coated angioplasty widened, especially after 6 months, speculating that the anti-restenosis effect of the paclitaxel is manifest after 6 months. Given this clinical scenario, factors associated with restenosis after 6 months differ than those with within the 6 months. So we conducted a retrospective study to identify the factors associated with the early and the late DCB restenosis. All patients are treated with standalone DCB therapy. After multivariate analysis, SFA ostial region and the presence of CTO are significantly associated with the early restenosis, while severe calcification and the small vessel diameter and involving the popliteal artery are significantly associated with the late restenosis. So this slide shows the 6 months primary patency stratified the early restenosis factor. The 6 months restenosis rate of the CTO originating from the SFA ostial was 15%. Based on my speculation, the mechanism behind the early restenosis could be due to the dissection, and the stenting may reduce the risk of the early restenosis. So in conclusion, the Capricorn's propensity matching analysis demonstrates the better 1-year restenosis rate for Eluvia DS versus Impact DCB. Retrospective single center study demonstrated the small vessel diameter and the nodular calcification are shared restenosis related factor for both DS and the DCB. Popliteal region and the plaque burden greater than 50% restenosis related factor for DS. Vessel preparation failure were restenosis related factor for DCB. So retrospective and the multi-center study demonstrated that SFA ostial region or presence of CT was significantly associated with the early restenosis within the 6 months for DCB. Significant late restenosis factor for DCB, including the calcification, the vessel diameter, and the popliteal artery region. Thank you for your kind attention.
Thank you very much, Osama. We're going to do the discussion after listening also, Thomas, to the same topic, but then the European view. I'm very curious to see if there is another way of viewing this difficult debate between Japan and Europe.
It's simply looking into different data, but I believe the conclusions are very similar. Well, what we learned over the time of, I would say, the last 20 years, and this is exactly when the foundation of this meeting happened, that patency outcomes did improve with technological improvements. So we started with a 1-year patency of about 60% for plain balloon angioplasty, and we are now at a level of 1-year primary patency outcomes of about 90% using drug-eluting technologies. There is a given difference between drug-coated balloons, obviously. Not every device is the same, depending on the overall drug dose on top of the balloon, depending on the excipient. But in average, what we learned is up to 3 years primary patency is, I would say, offering fair outcomes for most patients treated with femoral-popliteal lesions ranging from 64 to 77%. And these outcomes are usually better than using plain balloon angioplasty. Interestingly is that the outcomes of plain balloon angioplasty are getting better and better over time. That means we have learned something about how to properly prepare the vessel, even when we only use a plain balloon. So using the right strategy, either with POBA or with drug-coated balloon angioplasty is extremely important. Is there a difference between the performance of drug-coated balloons depending on high dose and low dose. Low dose defined as 2 milligrams per square millimeter paclitaxel as compared to high dose, which is the impact with 3.5 microgram per square millimeter. Obviously, in the compared trial, there was no difference. Low dose and high dose performance regarding primary patency at 1 year was very similar as compared to data from the Prospect study, which was a propensity score matched retrospective analysis, where at least the low dose DCB numerically did perform a little bit better than the high dose balloon. However, this difference is not significant. So overall, if we look into the outcomes of drug-eluting stents, in particular looking into the performance of the Eluvia stent using a long-term drug elution based on a polymer release of the drug up to 1 year, we see very consistent 1-year patency outcomes around 90%, regardless whether this was the first demand trial or the latest randomized controlled studies. So far, more than 2,000 patients had been enrolled with very different lesion and patient comorbidities. This is data on the early experience with Eluvia. As mentioned, most of the outcomes regarding primary patency had been at least in a range of 90% up to 96%, representing the best in-class outcome so far at 1 year for the treatment of femoral popliteal disease. And this is now level 1 evidence based on randomized controlled studies. The EMENENT study did compare the Eluvia stent versus a variety of bare metal stents in a 2-to-1 randomized fashion. More than 700 patients had been enrolled, showing an up close to 9% absolute difference in primary patency, favoring significantly the Eluvia drug-eluting stent. And at 1 year, almost the same difference was seen between the Eluvia drug-eluting stent and the Silver PTX stent. This is now, in addition, a multi-center post-market registry, the REGAL study, lesion length slightly longer than compared to the EMENENT randomized controlled study, with more complex lesions in the post-market studies. But anyhow, the primary patency outcome was even better as compared to the randomized control study with the less complex lesions, probably related to a less close follow-up control in the registry as compared to the randomized control study. Most recent data are coming from the sports randomized control study. What is sports? This is a study with the most complex lesions so far analyzed in a randomized controlled fashion, comparing bare metal stents with the Sequent Please drug-coated balloon and the Eluvia drug-eluting stent. This was a 1-to-1 randomized study with about 75 patients included into each study arm. And you can see over here, these are the lesion characteristics. Average lesion length about 22 centimeters in all 3 study arms with a high prevalence of total occlusions. Occlusion length overall about 18 centimeter roughly. Reference vessel diameter smallest for the DCB cohort, which may have had an impact on the outcome. Anyhow, important to mention that the bailout stent rate was not surprisingly high, of almost 60% in the DCB cohort, and it was 0%, of course, in the stent cohorts. And this is the lesion characteristics based on the PAX score. So more than 50% of all lesions in all the 3 study cohorts had been moderate to severely calcified. Rutherford classification, mainly Rutherford category 3. And regarding the baseline patient characteristics, no significant differences with the highest proportion of diabetic patients and renal disease patients in the DCB cohort. And this is now the primary endpoint. It's the comparison of diameter stenosis with the highest diameter stenosis seen in the bear-nitinol stent arm as compared to the DCB arm, and the best outcome has been shown for the drug-eluting stent at 1 year. And the predefined comparison between DES and bear-nitinol stent was proven, so the DES was superior to bear-nitinol stent, and the second study hypothesis was that DCB is non-inferior to bear-nitinol stent. And worth to mention that in this cohort, even the superior stent, considered as the best-in-class bare metal stent, was allowed to be used. This is now late lumen loss based on angiography. Again, the winner was the Eluvia drug-eluting stent with 0.5 millimeter only. So in conclusion, regarding the Europe view on how to best treat complex lesions today, no difference has been shown between Ranger, low dose, and Impact Admiral high dose DCB so far. Indirect via IDE trials or direct via the COMPARE trial. The Eluvia drug-eluting stent performance up to 1 year in complex lesions and highly comorbid patients is consistent across data sets as shown, including more than 2,000 patients today. 1 year primary patency is around 90% and translate to similar freedom from reintervention rates at 2 years. And the sports trial shows a patency and TLR benefit for the Eluvia DES over DCB and bear-nitinol stent at 1 year. However, longer-term follow-up is crucial. The decision for DCB versus DES use is mainly driven by operator preference and country-specific reimbursement systems. Thank you very much.
Thank you very much, Thomas. We're going to keep the discussion for a little bit later because we are going now directly to the live case in Tokyo. So can we set up the connection, please? Hello, Dr.
Hi, Cohen.
How are you? Dr. Nakama.
I'm fine, great. Thank you very much.
Not too stressed.
Okay.
You are looking not too stressed. Very good.
Yes, I really enjoyed.
So we are here in Main Arena 1 in Leipzig, debating already for minutes about DCB, DES, and I'm sure you're going to give us some more insights in this. Can you explain the case, please?
Okay, please quickly move to the case introduction slide. Okay, our second case is a 44-year-old male, and target region is also a left SF occlusion. He was suffering from Rutherford 5 toe alterations. Risk factors are shown, and we already recognized his occluded iliac artery from the radial artery. Please move on to the next. As you can see, angiography of the left SFA in previous session clearly visualized the left SFA occlusion. So today's our target region is this left SFA occlusions. So today we puncture the patient right groin, and the cross approach, probe approach was done using a 4 French EMEA catheter and thermosieve. crossover dedicated Cs was nicely past the little bit angulated iliac artery. As you can see, some of the calcium are observed. The length of the calcium is not so long, but some of the intimal calcification is observed at the 38 or somewhere, a little bit slightly tough region. As you can see, the SFA is completely occluded. This part of the SFA is clearly visualized from the peripheral artery flow. This length seems to be nice. The recanalization of the SFA is mandatory to get the better healing. We advanced the integrated system with B18 control guide wire with the backup support of the vertebral diagnostic catheter. It's a little bit hard, but we finally succeeded to in the CTO. Then we tried to keep the interlinear crossing, but it's very hard. It seems to be difficult to negotiate. Then so we have to switch the strategies. It seems to be very hard.
So Tatsuya, you chose immediately for an 018 platform, if I understood well, but then supported with an 035 catheter. Do you encounter some problems there? Is there for you place of starting with an 035 platform, or do you start routinely with the 018?
Basically, I started the 018 platform, but supported by the 035 platform systems like this. So if I feel that some of the difficulty to advance 035 diagnostic catheter, I sometimes inserted the 018 dedicated microcatheter, but I don't. Recently, I do not routinely use 018 dedicated microcatheter. 035 guide my diagnostic catheter is more cheap and it's sometimes sufficient.
But so you don't encounter problems with this, let's say, anatomical mismatch between an 018 guide wire and an 035 catheter?
Yeah, exactly. Sometimes encountered, but sometimes sufficient. So I do not routinely use. Anyway, so I try to advance the integrated wire with a loop technique. I try to twist the wire, but subintimal approach. Actually, this is a subintimal approach technique, but sometimes this kind of the narrowing loop wire is go into the interlinear space. But I'm not sure, so I was confirmation maybe needed to actual passage, confirmation of the passage route. Anyway, so some of the severe calcium prevent our procedure. Yeah, I finally gave up the integrated approach, then puncture the distal popliteal artery as well, like previous case. I finally succeeded to puncture the popliteal artery. The insert is also B18 control, 18 compatible systems. In this situation, I prefer to do a ceaseless technique with Carnelian support, 018 dedicated microcatheter from Toka Medical, Japanese company. Then I succeeded to establish the radiology systems. But distal cap is very calcified and also difficult to enter. 014 penetration guide wire succeeded to in, but it seemed to be very difficult to advance more. Then I tried to more stiff for 018 penetration guide wire. This is a little bit tough case.
But that's Tatsuya. You did very quick this retrograde axis, and I'm sure that
Yes.
in the audience there are some people having some questions on this. So you punctured the popliteal artery, the P3
Yeah.
segment. I understood the anterior wall, so you did a puncture from anterior in between the two bones, the tibia and the fibula, through the membrane, the interosseous membrane, into the anterior wall of the poplitea. Is it correct?
Yes, exactly. As you say, so we can clearly see the P3 segment between the tibia and the fibula bone. To maximally distinguish the both bone is quite important to get the adequate puncture position.
So, but
Anyway,
as you
yeah.
puncture the anterior wall, you can not do a manual compression afterwards. So,
Exactly.
then is it your recommendation not to use distal sheets or retrograde sheets or whatever, and just stay with the 018 wire and catheter?
Yes, exactly. For this technique, so C-thread technique is also always mandatory. So once this was inserted, it's sometimes difficult to stop the bleedings. Of course, sometimes possible. I strongly recommend that the balloon-assisted hemostasis using 5 mm balloon or something.
Okay, yeah.
Yeah, of course, but this insertion is sometimes required to get a sufficient backup force. Actually, in this case, it's very tough. It seems to be very difficult to get the distal of the CTO. It's a very tough. If we succeeded to puncture the distal cap and create some of the small hole, we get some of the lumen, but unfortunately, it seems to be insufficient.
So this is a dedicated CTO 014 guide wire with a heavy tip load?
Yeah, so this is 018. We already changed to the B18 control. We already created some of the small holes, but using 40 grams, very stiff guide wire. But this guide wire no more advanced. Then I want to change the strategies to subintimal approach from the retrograde sash fashions. It's very hard. If it was failed, I try to advance the undergrad wire more deeply and do a reverse cut technique from the more distal segment.
Dr. Ida, do you have some recommendations for your Japanese friend?
I think this is a very challenging situation because retrograde microcatheter has not enough backup force. Maybe it's very challenging. But anyway, the subintimal approach is very suitable for recanalization. And
Okay, so
my suggestion is the 035 wire from the antegrade fashion is one recanalization technique.
or using 035?
Yes, 035 from the antegrade.
Yeah, I completely agree. To create in the more subintimal space from the antegrade fashion, I think this is a very reasonable situation. As Osamu suggested, I tried to advance the guide wire more deeply.
The problem here is that you don't have enough support from the retrograde access. So what I'm usually do is I use a balloon catheter, 5 millimeters, so that means an appropriately sized balloon. Inflate the balloon proximal to the occlusion, and then you have more push with your guide wire.
So now in this situation, you can try to do a kind of car technique where you inflate a balloon from proximal and try to follow with your retrograde wire.
Exactly. So I try
there.
I try to advance the 5 millimeter balloon from the antegrade side and try to do a cut technique to create the constitution of the both lumens. I try to advance the starting 5 mm balloon from the integrated fashions because, of course, a non-compliant may be reasonable, but my impression is it's very difficult to deliver the very big profile non-compliant balloon from the integrated fashions because the region is very hard beyond our expectations. Anyway, I try to advance the 5 mm balloon inflation. Try to create the space depth. V8 新品用意しといて。10. In this situation, I think a subinterval approach may be suitable. Deflation. I completely dilate the whole of the antigrade space inflation using a 5 mm. 開けて。で、あと、スタートを先に用意して。デフ。
So is it for you a difference, Tatsuya, the fact
Yeah.
that you are like now recanalizing this in an intraluminal or a subintimal way? I'm speaking about outcome, result, final result, durability, and so on. Because you sound a little bit sad and disappointed that you go that you go subintimal. What is not the case in my philosophy. Subintimal is as good as intraluminal, but do you have a different opinion there?
Yeah, personally, I think there's not so huge difference between subintimal space and intraluminal space, but only one different point is, as Thomas mentioned, it's sometimes difficult to get the sufficient luminal area. It means difficult to get the successful reason preparation. Therefore, it's often difficult to finish with only DCB approach. Therefore, in this situation, I expected to the result will finish with drug editing stent or something or scaffold devices. I try to advance the 018 stiffer guide wire, try to penetrate the separation more between the intraluminal space and subintimal space. 6ミリのバルーン用意しておいて。デフレーション。デフレ。で、下は誰か支えててくれるか。Very hard.
So sometimes what I'm doing is also looking in another projection to see the distance between the wires. Sometimes you are surprised how far the wire, they look like very close, but sometimes there is a huge distance between them.
Yeah, as Koren mentioned, it's a very important suggestion. 話してちょっと。インフレーション14。It's very hard.
What are your impressions here?
Yeah, it's very hard.
Do you have some good Leipzig tips and tricks for Tatsuya?
Sorry?
I think he has chosen a great strategy. I would probably have punctured the distal SFA to have more pushability than going down to the P3 segment. What also sometimes is helpful to go for more antegrade support, to go for a telescope technique using also a guiding catheter if you need that. But I think he's almost there, to be honest. It's
a lot of very. There are many opinions, and I try to advance the retrograde wire with a loop technique.
Yeah, that's it. I think the looped wire technique from the retrograde approach is very.
Yeah. I completely agree. So I try to advance the wire using a lateral loop technique. Oh, outside?
Yeah, no, he needs to show the
No,
success wiring.
seems to be okay.
You are very close.
Yeah.
Very close.
6ミリのバルーンください。I tried to size up the balloon from the anterior side. Seems to be close. Then 5mm balloon is insufficient to break up the separation wall.
Do you have access in Japan to re-entry devices, B-back catheter, out?
Yeah, it is available. In this situation, using Outback is only a viable re-entry device in Japan. Inflation. 12、14、16、18。F。スタートちょうだい。I try to advance more and lateral wire more deeply. It seems to be very close. Start. Inflation. It seems to be very close. I try to puncture again. あれちょうだい。朝日のクロスリードの60ペネトレーションどれかつけて。If it's impossible to pass, so I try to use a more stiffer one diff. 300ください。
So we have actually one talk to go.
Yeah. Thank you very much.
But
Is it okay?
I mean, the audience is so so willing to see how you're gonna succeed this, and we are all
Thank you very much. Please move to
supporting
the.
you. So we stay a couple of
Thank you very
minutes
much.
with you and take your time. Don't stress. I'm sure you're
Thank you
gonna
very
make
much. During the talk, I'll do. Insert.
Tatsuya, be relax.
Thank you very much.
What about another suggestion is like the double balloon technique, and
Yes,
also
point very
integrating a
important.
balloon from retrograde, a smaller size, of course, just shoulder to shoulder, or just a little bit overlapping with the distal ends. Sometimes this can also break the membrane in between the subintimal and the intraluminal space.
Yeah, as Korean, so as you suggested, double band technique is very important technique in this situation. But as we already discussed, insertion of the CC is sometimes very challenging for this technique. Impression. Definition. サンプルのシーツください。But I finally decided to insert 3 French seats and exchange oscillative guide wire from the retrograde side.
Okay, so
Sample in the
so
sheets.
we give you some time to do this. We
Yeah,
move
thank
on
you.
with the next, and please record the moment of re-entry. This would be very
Okay,
great
thank you
to
very
show
much.
at the end.
Thank you very much.
Okay, thank you, Tatsuya, and see you in a while.
Yeah.
So we move on with the last speaker, and this is the man without a voice, Jan Goevik, with a lot of good ideas, I would say. So you're gonna give us the final surgical view on what not to leave behind. I mean, I'm very curious, Jan.
I'm gonna try to give you some view. First, I want to thank Colin Rob for Every time we have a very challenging discussion, and his input are very great to make this kind of presentation. So thank you, Colin. So I think that the objective of intervention is not to leave something or nothing behind, is to improve the patient, is to have a low rate of reintervention, is to improve the patency. This is the objective of intervention. And so we can also look at the lesson from cardiology. And so they have defined some factors like dissection and minimal stent area that could influence the MACE, the cardiovascular death, the myocardial infection, and the TLR. And for example, if you look at dissection, we know that we have different patterns of dissection. We have some classification. We have some dissection with minor radiolucent area, with linear dissection, with contrast outside the lumen. We have some spiral dissection and dissection with persistent filling detect, and finally, total occlusion. And we know also that, for example, a difference between spiral dissection with and without flow-limiting consequence. In fact, we have some difference, in fact. And thus, we didn't have, in fact, some difference. I mean that if you have spiral dissection with or without flow-limiting consequence, you can have a decrease of primary patency and freedom from TLR. Also, we have some factors that could influence the outcomes of spiral dissection, such as CLTI, long lesions such as TASC-D, and residual stenosis superior to 50%. We have no classification of dissection. It's a disform classification, and in case of disform 3 and disform 4, we should use a scaffolding to decrease the rate of loss of patency and reintervention. Another factor that could influence the occurrence of reintervention is the minimal stent area. I think we forgot too much since the last year that restenosis is not just a fact of intimal hyperplasia. In-stent restenosis or restenosis is a combination of three factors, three mechanisms. First, it is the elastic recoil, the early elastic recoil just after the balloon preparation. Secondly, it's of course the intimal hyperplasia. And the last mechanism to explain restenosis is the constructive remodeling. I can share you this example published a long time ago in 2012. In this case, it's a histologic view of the occluded SFA 1 month after POBA angioplasty to treat this long occlusion. The red dot, it is a subintimal localization. And you can see that in the red dot, we have the subintimal lumen, which is completely collapsed because of the lack of scaffolding. So scaffolding or good vessel preparation is mandatory, mainly in long occlusion and when you have calcification. We know also from DS without polymer that the suboptimal minimal stent area matters. And clearly in this study published by Osamu, we see that in case of low minimal stent area, we have a decrease of patency. Also, is also true in case of polymer-coated paclitaxel-eluting stent. When you have a suboptimal minimal stent area, you increase the restenosis during the follow-up. So you should take care of the lumen after the vessel preparation and the treatment. And so to have a good vessel preparation, you should focus on this result. You should have a good vessel preparation. I can share also these results of the old RCT comparing zivapetics and POBA. And in fact, we have two groups. A group with primary DS use and a group with provisional DS, so with a POBA as a vessel preparation. And clearly, after 1 year of follow-up, you can see that with vessel prep, so POBA as a vessel preparation, you increase the primary patency rates. So why not to use a scaffolding? And so what I heard as vascular surgeon, you prevent bypass. I said, no, you don't prevent bypass if you stent artery. Why? Because, in fact, when you perform a distal bypass, a femoral popliteal bypass, you have to choose, you have to touch the artery, the SFA, to choose an area without any disease. And so if you have previously a stenting zone, you don't find a stent in a healthy part of the SFA. And so when you perform the distal anastomosis of a fempop bypass, a stenting does not prevent the femoral-popliteal distal anastomosis. Does stenting prevent recognition? I said no. In my experience, it's pretty easy. You have a lumen. If you take care of the patient pretty quickly, you can remove the thrombus, make a thrombectomy, and you have a channel, you have the root, you have intraluminal loop with the stent, and it's pretty easy to make this recognition. You can add a stent, you can use DCB, whatever. And another concern is to geoderioparize the ostium of the DFA, the deep femoral artery. In fact, dealing with the DFA, according to this study, it does not affect the patency rate at early or later stage. You have no effect if you cover the origin of the deep femoral artery with a stent at the origin of the SFA. So nowadays, we have to choose a different option, and this option is based on paclitaxel, no bare metal devices. And we have no safety data from patient pool data, but also from real-world data. We have this data. We have also from real-world data showing that using paclitaxel devices, you decrease the amputation rate. And so, DS or DCB. And so people say, okay, be careful to this patient because of the life expectancy, don't use any scaffolding. If you look about national database, the life expectancy of patient after endovascular revascularization, it's almost 50%. I mean that more than 40% of the patients are dead 5 years after endovascular repair. Intraoperative finding is or not a POBA responder. It depends, of course, of the length, of the CTO, of the calcium, of the recoil. But so far, we didn't have the tool in my routine practice to assess if the patient is POBA or not POBA responder. It's too much complicated. And finally, we have also more and more RCT regarding long lesion, and they are pretty much in favor of DES use. And finally, perhaps it's the main driver of the use of DES or DCB, it is a cost effectiveness. And we have, in fact, two perspectives about the cost effectiveness. We have reintervention. It is a societal perspective, so for the community. And we have the hospital perspective. And the hospital perspective, it is driven by your level of DRG, and it is driven by your reimbursement. It is your real life, the reimbursement and the DRG. If you look at the reintervention, we know that using, for example, DS, we decrease very much the reintervention rate, and it could have an impact on the cost effectiveness. Why? Because if you decrease a lot using DS, for example, Eluvia stent, the reintervention rate, you have a cost for the reintervention. In the article published in the European Journal of Endovascular and Vascular Surgery, they show that the mean cost of TLR, or reintervention, is about 21,000 euros. And so if you have to treat 1,000 patients using a DS, using Eluvia, you decrease by 400,000 euros the cost. It is a cost effectiveness in this case. So to conclude, unsupported recall or dissection can lead to reintervention. Severe dissection as disform 3 and 4, including spiral dissection without flow impairment, should be identified and DS treated. Optimal DS treatment requires an efficient vessel preparation and accurate sizing. Get it right first time. Long DS treatment does not prevent open surgery or future instant recanalization. And finally, cost effectiveness could drive the increased use of Eluvia DS. Thank you for your attention.
Thank you, Jan. Very short question, very short answer. Is there in your daily practice one indication for non-drug eluting technology treatments? Peripheral arterial disease treatments?
For none?
Yes. bare metal stent, POBA, whatever. Non-drug eluting.
Bailout stenting.
Bailout stenting post-DCB.
50% of the cases in case of long lesion.
Okay.
So we should have still a bare metal stent. It's mandatory because it's mandatory in case of 50 to 60% of the...
Not as a primary treatment.
No.
Okay, thank you. And then a question, very short question and short answer for Thomas and Osamu. Very short, in your daily practice, when a DCB and when a DES? Which indications?
So indication for DES for the vessel preparation failure. The borderline with the DES or DCB is the result of the vessel preparation.
Good. Thomas?
Yeah, well, pre-dilatation with a regular size balloon, meaning at least 1:1. If there is dissection, thrombus formation, then I would place a DES followed by DCB for the remaining segment, which looks perfect, or meaning responds well to POBA for pre-dilatation. So it's the combination of different drug eluting devices, stenting where a scaffold is needed, there are DES, and the remaining part I use a DCB.
Fantastic. Thank you very much. I think we can go back to Tokyo for the finalizing parts of the work. Do you hear me, Tatsuya? Yeah.
Yes.
First of all, I need to congratulate you with your recanalization. You made it.
Yeah. Thank you. Today I'm very lucky. So.
No, you are very good.
It's very challenging.
You are very good.
So,
you are not very lucky.
I finally decided to insert the exchange the whole of the retrograde system to O35-1. Firstly, I inserted 3 French Cs, but if I want to use the O35 guide wire, 3 French Cs is not dedicated. So I inserted O35 guide wire and performing C-slash technique, 4 French CXI support catheter. I deeply inserted the 4 French CXI and aggressively performed the subintimal approach using O35 thermostiff. Finally, we succeeded to break up the retrograde CTO cap with very, very strong system, O35 stiff and CXI support. Then we finally succeeded to externalize the wire. It needs a little bit time. Anyway, dilate the whole of the region with 4mm balloon. This is angiography after the 4mm balloon dilatation. Its severe dissection was observed as we expected. So, as Thomas mentioned in the discussion, deployment of the before the deployment of the DES, aggressive lesion preparation is mandatory and necessary to prevent restenosis. It means reducing the residual stenosis is quite important to keep it open. Then finally, we decided to open up the whole of the region using a 6mm non-compliant balloon. We add very high pressure. This is a angiography after the 6mm balloon plasty. We did not confirm the IBUS result, but it seemed it's very nice. Then I deployed the 7x150 LBR. Then now I try to deploy the second LBR. Also 7x150. As you can see, we already performed a good vessel preparations. Without post-dilatation, its stent open is not so bad. Of course, it's need more aggressive post-dilatations. 80, 7の80. We need additional one stent.
So we agree, Tatsuya, here in this case, that we don't need IVUS. It was quite obvious that it was suboptimal, that it was dissected, that there was recoil, that there was spiral dissection. So no need for IVUS, also not in Japan?
Yes, as Osamu mentioned, we do not routinely use IBUS. Approximately 60 to 70%. It's completely depending on the operator. In my institutions, approximately 6%, 60% of the procedure they were performed IBUS guided. So, but last 40% is not. It means we understand each phenomenon with only angiography in these situations. Using IBUS is not always necessary. I think so using IBUS is very, very important, but I think no feedback knowledge from the IBUS is quite important.
So we are running a little bit out of time, but so what are the plans? A short Illuvia proximally?
Yes,
And
yes, exactly. We deployed additional RBI. This is the last one.
yeah.
So
And you end it
There's
right at the ostium of the SFA?
No
yes, exactly. We
Or you plan to
recovered the, yes.
Yeah.
This is the last RBI.
I'm very
Yeah,
curious to see an angio now.
Yeah. Okay, I take a quick angiography quickly. DSA.
Yeah.
This is a before post-dilatation, but I think the stent seems to be already nicely opened. Of course, additional post-dilatation is very good and necessary, but due to the good lesion preparation using a non-compliant balloon, I think this result seems to be very nice.
Last injection. Yeah.
Okay.
Amazing job, Tatsuya. Congratulations. You're going to do a
Thank you very
nice
much.
post-dilatation and the patient will be very happy. I want
you very
to
much. We will do.
conclude the session here. I would like to thank Boston again for the support, all my speakers. You did a great job, and of course, you for your attention. Thank you.
Okay.